exhaustive topic uh, about recent advances in ENT, because the recent advances also keep changing every time, right? What was recent advance 10 years ago, cochlear implant, is no longer a recent advance. Okay, so it keeps changing and changing, as we shall see in the coming slides. So before I start, I just want to put into the people who are listening that this whole presentation is not an exhaustive list, because literally every chapter in ENT has got some recent advance. Every section in ENT has got some recent advance. Things are changing by the hour. So I have tried to summarize what I feel is the recent advances that a postgraduate should know. The list is not exhaustive. There may be many things that has fallen through the net. You can of course reach me and let me know for future presentations. I will include those topics. For now, I'm trying to give an overview of the recent advances that have happened in the ENT in the past 5 to 10 years. And no, I will not be talking about cochlear implant. Cochlear implant is not a recent advance. It's become an old advance now. Okay. Yes. One of the recent advances is the advent of tissue engineering in otolaryngology. This is especially relevant in the context of larynx, because whenever you do a laryngeal surgery, be it a microlaryngeal surgery or any external surgery, there is always some scarring. And the objective of tissue engineering is to prevent the scarring and to give vocal fold restoration. So larynx, superficial layer of the lamina propria, and you can inject therapeutic materials which are usually collagen and fat. So by tissue engineering, we are trying to avoid collagen and fat because they don't have optimum elastic properties. And one more concept in tissue engineering in ENT is the vocal fold regeneration. Vocal fold regeneration itself may come as a question for you guys. So as you see the structure, ultrastructure of the larynx, there is a superficial layer of lamina propria, and there is a space underneath that which is called a Reinke space. The superficial layer of the lamina propria is literally gold. Whenever it is disturbed, there is going to be some scarring. So the objective is to prevent scarring of the vocal cords. So tissue engineering, there are three parts of tissue engineering. One, you have to understand tissue engineering like a building, right? So you have building, you have people, and then you have some reason why they come and stay in the building, right? So the building is the scaffold which holds the cells, and then there are the cells who are the inhabitants of the building, right? People who live in the building. Your building mein rehte. And then the bioactive factors that make the cell live and thrive inside the building. So tissue engineering has got three concepts: the building, which is the scaffold which holds the cells, and then there are the cells themselves, which are the inhabitants of the building, and then there are bioactive factors which leads to the cells growing inside the building. So the building, the inhabitants, and the bioactive factors, three parts of the tissue engineering. So tissue engineering, especially in relevance to vocal fold regeneration, vocal cord regeneration, the development and implementation of scaffolds, use of bioactive factors, and use of cell therapy. These are the three parts of vocal fold, vocal cord regeneration. So scaffolds, cells, and factors. And then there is one more called mechanotransduction, which is the mechanical properties of the cells are restored. That is called mechanotransduction. So the scaffold or the building, the cells or the people who live inside the scaffolds, and the factors which allow these cells to grow. These are the three parts of tissue engineering, or three parts of the vocal cord regeneration or vocal fold regeneration. The scaffolds, they are three-dimensional lamina propria replacements. They are synthetic biomimetic hydrogels. They are basically gels which holds the cells. There are two types of scaffolds: the biological scaffolds and synthetic scaffolds. The biological scaffolds are biological polymers, and synthetic scaffolds are acellular biological scaffolds. Basically, they are gels which hold the cells together. Most commonly used scaffold is acrylated polyethylene glycol derivatives. Okay, so I told you tissue engineering has got three steps: the building, the people, and the factors which make them live in the building, or factors that cause them to grow. The scaffolds are made up of basically replacement of lamina propria, and they are made up of hydrogels. They are made up of gels which hold the cells together. Cells, where do you get the cells? So either you can take the autologous fibroblasts from other parts of the body. You can also use embryonic stem cells. You can use stem cells derived from the bone marrow, which is called bone marrow derived mesenchymal stem cells. Or you can use stem cells from the fat tissue, which is called adipose derived mesenchymal cells. So these are the cells or the inhabitants which live inside these scaffolds. So these are some of the types of cells. So please remember one or two type of cells and write it if this question is asked. And what causes? See, just putting the cell in the scaffold won't allow the cell to grow, right? So you have to make the cell grow inside the scaffolds. So how do you make it grow? You basically use some growth factors. So what are the growth factors that are commonly used? Basic fibroblast growth factor and hepatocyte growth factor. These are the two things that are used in making the cells grow. What are the other places where tissue engineering is being used? One is in bone restoration, osteoinduction, osteoconduction, and osseointegration. Osseoinduction is the recruitment of osteocytes or calling the osteocytes. Osteoconduction is migration of the osteocytes onto the prosthesis, titanium prosthesis or whatever. And then osseointegration is joining of the prosthesis with the human body. So it is very commonly used in craniofacial and of course dental, right? Where they put titanium screws and all that for replacement. It's very common in dental, less common in ENT. It's used in facial-maxillary reconstructions. What are the scenarios where you need this kind of reconstruction? One is in ENT is the osteoradionecrosis of the mandible following radiation therapy. Second is segmental mandibulectomy defects for oral cavity, especially lower jaw malignancies. So you have segmental defects. So you basically use these for the reconstruction of those segmental defects. Second use is the necrosis of the mandible following radiation therapy. What you use is bone marrow derived mesenchymal stem cells. These are used for craniofacial reconstruction. What are the other applications of tissue engineering in otology? Tympanic membrane reconstruction, ossicular reconstruction, outer hair cell regeneration. So these are some of the applications. Of course, none of these has found any clinical use till this date except for vocal fold regeneration. None of it is actually being clinically implemented. So what are the other applications? Your reconstruction of the or regeneration of the tympanic membrane, reconstruction and regeneration of the ossicles, and regeneration of the outer hair cells. Now a little bit about the biomaterials, some of the biomaterials that are commonly used. Now why am I telling you this? Because these are a little bit of an older biomaterials, because I'll be talking about some newer biomaterials that are available and that are going through clinical trials right now. This itself can be asked as a question. For example, fibrin glue can be asked as a question. Mitomycin C can be asked as a question, short notes. So fibrin glue consists of human thrombin and fibrinogen mixed with amino acids and salts. And as you all know, it is most commonly used in CSF rhinorrhea repair and of course following transpyramidal pituitary surgery, right? For plugging transpyramidal pituitary surgery and for plugging CSF rhinorrhea. Basically, it's used for plugging some defects. Second is mitomycin C. Mitomycin C is now frequently used in your vocal cord surgeries because it prevents scar formation of the vocal cords. So mitomycin C is the substance that inhibits fibroblast proliferation, so it reduces scar formation. So it cross-links DNA and inhibits cellular mitosis. So it is most commonly used in laryngeal surgeries. Though another scenario where it is commonly being experimentally tried out is the post-operative FES. As you all know, you're all senior students, you already know the most common complication, late complication of FES is adhesions or synechia formation. So you don't want the nasal cavity to form synechia and jam, right? That defeats the purpose of doing a FES. So you can prevent that by applying mitomycin following a FES, right? You do FES and then you apply mitomycin, scar formation or adhesion formation will be less. So these are some of the applications of mitomycin C following vocal cord surgeries, all form of vocal cord surgeries, because you don't want the lamina propria to get scarred. Because it gets scarred, the vibratal properties of the vocal cord are changed, and then the voice becomes hoarse, and patient satisfaction is much less. So scarring, poor patient satisfaction. To prevent that, you can use mitomycin C. Likewise, following FES, adhesion of the nasal cavity, to prevent adhesion of the nasal cavity, you can use mitomycin C. And of course, subglottic stenosis. There also there is a role because fibrosis plays a very important role in formation of subglottic webs and stenosis. So you can apply mitomycin C there also. So please remember, if mitomycin C is asked, These are the things you have to tell. These are the indications for mitomycin C. Another new materials. So these are the older materials. You already know, probably some of you working in higher centers might be using these materials. But this is a new materials that is slowly coming into market. One of the materials is platelet gel, right? So platelet gel, if I'm going to talk about biomaterials, that itself will take 1 hour. So I'm going to be brief. So platelet gel is fibrin tissue adhesive products and consists of platelet-rich plasma, microporous polysaccharide hemispheres. It is made up of purified potato starch and it quickly extracts fluids from the blood and it is used for hemostasis, what is called MPH. MPH gel is used for hemostasis. Microporous polysaccharide hemispheres. Chitosan gel, again new material, and I am seeing Facebook ads for this chitosan gel. It is made up of chitin. Chitin is nothing but the outer hard layer of the insect. You know, you have the insects, their outer hard layer is made up of chitin. That's what a cockroach is made up of. So this is a natural biopolymer. It is achieves hemostasis and inhibits fibroblast proliferation. So a gel made up of that substance is called chitosan gel. Basic use is preventing excessive blood loss and achieving hemostasis. Another gel that is coming up is carboxymethylcellulose gel, CMC gel, and mesh. Again, this is used for nasal packing. Then advantage is that it causes hemostasis. And finally, there is one more gel called FlowSeal. FlowSeal is gelatin matrix, bovine derived combined with human derived thrombin. Again, advantages hemostasis. So chitosan gel, carboxymethylcellulose CMC gel, and FlowSeal. These are some new hemostatic materials. Now let's look at one more concept, recent advance in ENT. Now it's a burning issue. It's what is called gender affirming otolaryngological care. What is gender affirming? Gender affirming is somebody who is born as a male does not want to sound like a male, he wants to sound like a female. Somebody who is born as a female does not want to sound like a female, want to speak like a male. So you can convert the gender from one to another, and this is called gender affirming otolaryngological care. So basically, gender affirming otological care is for lesbian, gay, bisexual, and transsexual communities. It is for those people and for helping those people, and it's a burning topic in ENT. So help the patients get the gender they want. If you want to sound like a male, you can make them male. If they want to sound like a female, you can make them female. If you want to sound the lower pitch of the voice, you can make them lower pitch of the voice like a male. If they want a higher pitch of the voice like a female, you can make it like that. So that is called gender affirmation laryngoplasty. That is asked, you have to tell this. Gender affirmation laryngoplasty. It is basically Ishki's laryngoplasty only. That is given in Dhingra, right? But here the objective is to make the person happy with whatever gender they want. That is the concept of gender affirmation. Masculinization and feminizing laryngoplasty. So basically you do cricothyroid approximation or endoscopic shortening. Another thing that can improve voice is laryngoplasty with thyroid elevation. One another aspect of gender affirming otolaryngological surgery is the facial gender affirmation, facial plastic surgery. So make a person's face resemblant more of male or make a person's face resemblant more of female by removing excess hair. Another aspect of gender affirming otolaryngological surgery is the gender affirming hormonal therapy. So you can give hormones also. So if you give estrogen, the voice will become lower pitch. If you give testosterone, the voice will become high pitch. So three parts of gender affirming ENT surgery. One is laryngoplasty, second is facial plastic surgery, third is hormone therapy. So these are the three things you can do to help LGBT people achieve whatever gender they feel they are comfortable with. Okay, now let's look at, again, this is recent advances. I am just jumping from topic to topic. This is another recent advances, newer MRI protocols in the diagnosis of cholesteatoma. So if you are interested, you can look up my article. I have written an entire article on what is new going on in the diagnosis of cholesteatoma. You can find my article in the ACTA Scientific Otolaryngology journal that I published last month. The entire article is talking about what is new in cholesteatoma. But what I want to focus in this lecture in brief is that the new MRI protocol for diagnosis of cholesteatoma. The new MRI protocol is called diffusion wave imaging. So diffusion wave imaging is the new protocol for diagnosing cholesteatoma. So what is the advantage? What is diffusion wave imaging? The diffusion is the nothing but diffusion of water across the tissues. So tissues have different water diffusion, right? So water moves across the tissue by its natural random motion, and reduced diffusion in cholesteatoma will cause the signal to appear bright. So signal appears bright because of reduced diffusion of the water in the cholesteatoma, and the signal appears bright in T2 just like most tumors. Most of the tumors will have a bright signal in the T2 protocol of the MRI. Likewise, cholesteatoma also will have bright, but at the same time there is reduced diffusion having high signal on diffusion weight imaging. What is the advantage of diffusion weight imaging is that granulation tissue, polyp, inflammation, fluid, all these things that are confused with cholesteatoma will have low signal on diffusion weight. Why? Because polyp is nothing but fluid, right? So water will move freely through the fluid. If water is moving freely through the fluid, it will appear as less signal in diffusion weight imaging. In cholesteatoma, water will not move freely, so cholesteatoma will appear as high signal in diffusion weight. Ulta hai, huh? Please understand this ulta concept. If water is moving freely, like for example fluid or a polyp or a granulation tissue or an inflammation, it will appear as low signal in diffusion weight imaging. But here in cholesteatoma, the water will not move freely through the tissue, so it will appear as a bright signal. So diffusion viewed imaging. So what is the current role of diffusion viewed imaging? It is the best investigation or the most accurate investigation. If somebody asks you, you want to find out residuistic cholesteatoma. Recidivism means recurrence, ability of the cholesteatoma to recurrence, to recur. That is called residuistic cholesteatoma. So recidivistic cholesteatoma, recurrent cholesteatoma inside a reconstructed mastoid cavity. How will you make a diagnosis? Using diffusion weight MRI scanning. That is the answer. Current evidence says that diffusion weight imaging is the most accurate imaging for diagnosis of recurrent post-operative or recidivistic or residual post-operative cholesteatoma. So the role of diffusion weight imaging is the post-operative cholesteatoma surveillance. So this is what it looks like. You can see the whitish appearance. I already told you, diffusion kam hoga to white hoga, diffusion zyada hoga to black hoga, right? Simple answer. So diffusion kam hai, isliye white hai. Okay? Measuring the free motion of water molecules within the tissue. Each proper tissue has a characteristic diffusion property. Extracellular components have free diffusion, right? And intracellular components have limited diffusion. And there are two protocols in diffusion weight imaging, what is called echoplanar and non-echoplanar. Okay, echoplanar and non-echoplanar. So there are two protocols within this diffusion weight itself, echoplanar imaging and non-echoplanar imaging. Okay, so what is the best method for diagnosing cholesteatoma is non-echoplanar imaging. So if somebody asks you what protocol to give, so as a clinician you have to suggest the protocol. So the protocol for diagnosing recurrent cholesteatoma or residual cholesteatoma is diffusion weight MRI scanning, non-echoplanar imaging. So that is the prescription you have to give to the patient. Newer diffusion weight imaging in post-operative cholesteatoma. Diffusion weight imaging is the most accurate imaging investigation, but it suffers from one problem. If there is wax, it will come as false positive. Wax also has similar diffusion weight imaging as cholesteatoma, so you should remove all the wax before sending. Very important, before sending the patient for MRI. If you are telling शायद cholesteatoma recur हो रहा है, suspect कर रहे हैं, so you should remove the wax before sending the patient for doing an MRI scan. But advantage is that petrous apex, mastoid tip, deep location in the obliterated cavity, especially when you have obliterated the cavity with bone wax or some biomaterial, or when the tympanic membrane is intact and there is a cholesteatoma recurrence behind the intact tympanic membrane. All this can be easily detected by diffusion weight imaging. Okay, so petrous apex, mastoid tip, deep location in an obliterated cavity, and cholesteatoma medial to an intact and opaque tympanic membrane. All this will be easily detected by diffusion weight imaging. Only one problem, patient has got a wax, you have to remove the wax. Remember, wax के साथ भेज दोगे तो wax की वजह से cholesteatoma के जैसे picture आ जाएगा. So you have to remove the wax, then send the patient for diffusion weight imaging. Very important point, remove the wax in the cavity before sending for doing a diffusion weight imaging, especially if you are trying to look for recurrent cholesteatoma. Another new technology in rhinology that I am going to talk about today is balloon sinoplasty. So balloon catheter technology, otherwise called balloon sinoplasty or balloon sinus surgery. So balloon catheter technology Another name is balloon sinuplasty or balloon sinus surgery. What is balloon sinus surgery? Basically, you put a balloon into the ostia of the paranasal sinus and you inflate the balloon so that the ostia is enlarged. Just like the principle of FES, but here completely non-invasive. You are only using a balloon to enlarge the ostia and not enlarging it manually like you do in FES. So balloon sinus surgery or balloon sinuplasty. Mind you, it can be used for frontal, it can be used for maxillary, it can be even used for sphenoid. It cannot be used for ethmoid because ethmoid sinuses don't have very clear ostia. So it cannot be used for ethmoid sinus, right? Variable ostia. So you cannot use for ethmoid sinus. It is for frontal, maxillary and sphenoid, which have a definite and clear-cut ostia. So here you can see the balloon sinus probe, and you cannot use it in presence of polyp. You can use it as a treatment for chronic rhinosinusitis. The indication is treatment of chronic rhinosinusitis, not responding to medical therapy. So this is what it looks like. So the problem with balloon, this is Medtronic Nuent balloon dilation system. So you have various angled balloons, various angles, and you have a lighted guide wire to localize the balloon. So if to see where the balloon is going, you have a lighted guide wire. So it is used for maxillary, frontal and sphenoid sinus. And of course, the patient must be greater than 12 years of old. And the indication is only one indication, chronic rhinosinusitis, which is not responding to medical therapy. And patient is more than 12 years of age. Now, there are three types of guidance systems. Basically, balloon sinuplasty, you're putting some balloon into the sinus. How do you take the balloon into the sinus? Balloon pahunchega kaise sinus ke andar? So how does the balloon reach the sinus? So that is what is called the guidance system is required. So one type of guidance system is fluoroscopic guidance. You put the balloon and look for it in the fluoroscopic scheme. The problem is high radiation to the patient. Second is direct visualization. Direct visualization is via the lighted scope. So you can directly visualize on a patient's body itself, the light coming from the paranasal sinus. And of course, there is lighted guide wire localization system, which is the most complex and will give you a clear visualization of the location of the guide wire. What is done is initially you put a guide wire, then you use Seldinger's technique. You know what is Seldinger's technique? You insert the guide wire, then you insert the catheter on that, and then you remove the guide wire, right? That is Seldinger's technique, usually used in putting venflaps, right? Same thing you do in paranasal sinus. You insert the guide wire, then you insert the balloon, then you remove the guide wire. Same technique is used in percutaneous tracheostomy, right? I'm not even going to talk about it. Percutaneous tracheostomy, right? So percutaneous tracheostomy, same technique, Seldinger's technique. So here also it is being used. So if Seldinger's technique in ENT is asked, you have to write about balloon sinuplasty, and you also have to write about your this thing, percutaneous tracheostomy. And AOHNS, American Association of Otolaryngologists, says that the balloon sinuplasty is an appropriate therapeutic option for patients who suffer from chronic rhinosinusitis. Next, let's talk about newer advance in ENT, what is called powered instrumentation in ENT. Power instrumentation in ENT. One of the important power instrumentation in ENT, which is now being used literally everywhere, is microdebrider or Hummer. So let's look at what is new in microdebrider technology. Microdebrider have become an essential tool in modern endoscopic sinus surgery. They rotate at around 1,600 rotations per minute, and they have 2 to 4 millimeters blade. So newer blades are coming up, which are cloverleaf shaped blades, and of course angled blades. Microdebrider technology is used in doing turbinectomy and removal septoplasty. And then there is image guided microdebrider technology. Okay. And then there are endoscopic burrs, basically used for drilling out bone in frontal sinus operation, especially draft 3 operation. And of course, your diagnosis or rhinostomy, and you have septoplasty. So these burrs, they have much higher rotation rate. They are rotated around 15,000 to 30,000 rotations per minute. So endoscopic burrs and then microdebrider. These are two powered instrumentation, endoscopic burr and microdebrider. So this question was asked in an interview to me, and unfortunately I didn't know the answer. He was going on pestering me, tell the modes, tell the modes, tell the modes. So there are 2 modes of working of your microdebrider. Microdebrider works by oscillatory mode and rotatory mode. In oscillatory mode, you use it for removing soft tissue like polyp. It has very slow rotation speed, up to 5,000 revolutions per minute, and it removes the soft tissue basically. Okay, it removes the soft tissue. And then there is rotation mode, which is used for cutting through the tissue. It is not used for removal, it is cutting through the tissue because it rotates very fast. So it just cuts through the tissue and does not have time to suck it into the liberator blade. So oscillatory mode for removing polyps and rotation mode for cutting. So please remember oscillatory mode and rotatory mode. Lest you meet the same examiner in interview, go on asking the same question again and again. So the question is oscillatory mode and rotatory mode or rotation mode. Rotation mode is for cutting the tissue and oscillatory mode is for removing the soft tissue. Now another recent advance in microdebrider technology is energy equipped microdebrider blades. What are energy equipped microdebrider blades? This concept is that the microdebrider blade will do suction. It will also be used for hemostasis. It will also do monopolar cautery, and so it can be used for terminated reduction and adenoidectomy. So this concept is called energy equipped microdebrider blade. This concept is called energy equipped. Basically, already microdebrider is cutting and sucking. In addition, it will start using monopolar or bipolar cautery also. So that is called energy equipped microdebrider blades. Now, one more technology that is new is coblation. Coblation is basically formation of plasma, right? Plasma, which leads to disruption of molecular bonds and allows tissue to dissolve. Bipolar radiofrequency ablation, it works at low temperature, basically forms plasma and disrupts molecular bonds. The main advantage of coblation is less postoperative pain. Where it is being used, it is used in submucosal inferior turbinate reduction. It is the main and the most important use of coblation in rhinology. Other places where it is being used is tonsillectomy, adenoidectomy, nasal polyp removal, encephalocele, JNAs, juvenile nasopharyngeal angiofibromas, and skull base surgeries. So these are some of the places where coblation is being used. So let's look a little bit about the coblation. First is radiofrequency ablation. उसमें एक type है coblation. So remember, radiofrequency ablation is a blanket term. There are two types of radiofrequency ablation: monopolar radiofrequency tissue ablation and bipolar radiofrequency tissue ablation. In that, bipolar radiofrequency tissue ablation is also called coblation. Okay, so please remember, the radiofrequency surgery or radiofrequency tissue ablation has got two types: monopolar and bipolar. The bipolar is called coblation. Coblation stands for controlled ablation of the tissue, which occurs at relatively low temperature. The main advantage of coblation is there is minimal collateral tissue damage. Ajubaju ka tissue is relatively spare, and that coblation extends only 2 to 4 millimeters of depth. So coblation करेंगे तो tissue depth ज़्यादा नहीं, only 4 millimeter तक ही जाएगा. But unipolar radiofrequency tissue ablation has more depth, up to 20 millimeters. What are the advantages of coblation? Reduced blood loss, as I told you, improved visualization, reduced thermal injury to the surrounding tissue. Of course, all this, if for any recent advance they ask you what is the disadvantage, it is a higher cost of surgery and potential adverse effects on functional epithelium. For example, if you are working near the vocal cords, you don't want to damage the superficial layer of the lamina propria. So unnecessarily, this coblation can damage the functional epithelium, and it is a recent advance. So there are no long-term studies on the outcomes of the coblation. So that is another problem of or disadvantage of coblation. Another recent advance that has come up, especially in relation to bones, bone in head and neck and rhinology, is ultrasonic aspirators. What is ultrasonic aspirators? They are just like microdebriders but for the bone. These use ultrasonic vibration to remove both mineralized and non-mineralized tissue. The external field or piezoelectric material causes rapid compression and expansion of the tissue. It is mostly used in dental. So remember, microdebrider is for the soft tissue, ultrasonic aspirator is for the bone. So it is mostly used by the dentist. So where it is being used? By dentist and oral facial maxillary surgeons. maxillofacial surgeons. So it is used in implant placement, for doing leaf-forward osteotomies for the midface, for doing rhinoplasties, medialization laryngoplasties, inferior terminoplasty, EDCR, which is endoscopic DCR, transpineural pituitary surgery, and extended functional endoscopic sinus surgery. Like for example, if you are going to do an optic decompression, so extended fess. So these are some of the places where you need to remove bone, and you can use ultrasonic aspirators. So remember, ultrasonic aspirators are for bone removal. They are work at around 25 to 30 hertz. They move the tissue and break the bone. They have the unique ability. So the main point about ultrasonic aspirators is that they have the unique ability to remove the bone while sparing the soft tissue structures. So if somebody asks you what are the powered otolaryngology instruments, so these are the three main: high-speed drills, microdebriders, and ultrasonic aspirators. If I'm not mistaken, somewhere it has been asked, enlist the powered instruments in ENT and advantages and disadvantages and uses. So the advantage, disadvantage uses is there: ultrasonic aspirator for bone, high-speed drill for bone, and microdebrider for soft tissue. Okay, all have the disadvantage of increasing cost, and all have the disadvantage of affecting the normal tissue. All have the disadvantage of newer investigations. So we don't have long-term studies about these, but each one has got their own method of action, right? Ultrasonic aspiration by ultrasonic, high-speed drill by rotation, and microdebrider again by rotation. Okay, so please understand this for bone, and for soft tissue. Okay, so that is about the powered instrumentation in otolaryngology. Please remember, ultrasonic aspirators, high-speed drills, and microdebriders. Three parts of powered instrumentation. Okay, and microdebrider is also called hammer, by the way. Continuing on, technology, newer technology in ENT. So one of the new technology in ENT is telemedicine. So telemedicine has the hope of providing technology to the patient who is situated very remote and very far away from the patient. So people can interact with doctors through telemedicine platforms, teleconsultation platforms. So this is a new technology advancement in ENT. And another telemedicine extension of telemedicine is robotic telesurgery, right? So the doctor can be in one room, the patient can be in another place, even in another continent, but the robot will operate, and the robot will be controlled by a person or by a doctor, the surgeon, who is in another place. And through internet, high-speed internet, these commands are transmitted from the surgeon to the robot, which does the operation. So main important robotic surgery is called Da Vinci surgical system, and the main important robotic surgery is transoral robotic surgery, what is called TORS. And main indication for TORS is T1 and T2, limited malignancy of the oral cavity and oropharynx. So the main role of robotic surgery in ENT is oral cavity, oropharynx, supraglottic lesions. So please remember this: robotic surgery in ENT is limited to skull-based surgeries, your oral cavity malignancies, oropharyngeal malignancies, and supraglottic malignancies. So these are some of the places where robotic surgery is being used. Of course, some parapharyngeal tumors can also, especially medially placed parapharyngeal tumors, can also be dealt with robotic surgery. Okay, continuing on, one more important concept, I don't know if it is the recent, but it's still there from the past, is transtympanic perfusion of steroids. It is a novel and exciting therapy because it can selectively deliver the drug to the middle and the inner ear. And transtympanic perfusion of steroids or drugs can achieve high concentration of drugs within the cochlea and the vestibule, and can avoid the systemic side effects. So there are only two main uses for transtympanic injection. One is sudden sensorineural hearing loss. Second is Meniere's disease. In both these conditions, you can give steroids. In Meniere's disease, you can attempt vestibular ablation by giving gentamicin. So Tini a total, very simple. Sudden sensorineural hearing loss and Meniere's disease, both you can give steroids. In Meniere's disease, you can give for gentamicin to attempt vestibular ablation. So this is the technique for injection. Basically, you anesthetize the tympanic membrane with phenol in the posterior inferior quadrant, and then you use a tuberculin syringe, 1.5 inch long and 25 gauge needle, 0.4 ml of 40 mg of methylprednisolone or dexamethasone you can inject. Patient should remain in the same position for 30 minutes and avoid frequent swallowing. You perform 3 injections, performed twice weekly, So this is the frequency. 3 injections performed twice weekly. If the patient has got venous disease, you inject dexamethasone 4 ml per mg solution, injected once daily for 4 days, followed by a period of observation. So this is the injection protocol that we are using. So that is your transtympanic injection of drugs. Okay. Another new concept is tinnitus. Till this date, tinnitus has no effective medical therapy. So they are thinking that it is due to modulation of different potassium channels that tinnitus is happening. There are hundreds of drugs in the market. They will come and tell you this drugs works wonders, that drugs works wonders, these medical reps. But actually no drugs works. The literature is very clear. If you go through the literature or the textbook, the efficiency is not supported by any strong evidence. None of the medicines they work. Ginkgo biloba, B complex, antioxidants, even green tea, so on and on, so much. But none of this is having an effect against the tinnitus. It is one condition that has got, it's very difficult to treat medically. And there are very limited drugs that actually work, though many are available in the market. But there is one drug that has an effect on tinnitus, is intravenous lignocaine. If somebody is given intravenous lignocaine, the tinnitus is immediately ablated. It is immediately gone until the effect is achieved. And some senior ENT surgeons used to give intravenous lignocaine bindas. Nothing used to happen. But now we are not giving because of we are afraid of causing tachyarrhythmias, right? We don't want the patient to go for a ventricular fibrillation, which is life-threatening, for treating tinnitus, which is not life-threatening. The only positive effect of tinnitus is of intravenous lignocaine. So this shows that there is some pharmacotherapy should work for tinnitus. But unfortunately, none of the drugs that have been trialed this day has come to the clinical use. And the truth is that no drugs has works. So why am I saying this? This is an avenue for research. Young ENT surgeons can start working, because if lignocaine is working, it is definitely working on some channel, right? So definitely there is some medicine that will work and stop the tinnitus. That will be effective against tinnitus. But till this day, it has not been discovered. It has not been marketed. So it is an open this thing for the younger generation of ENT surgeons to search for medicines for tinnitus. Okay. Next topic is biologic therapies. Biological therapies. These are antibodies, okay, which are used in ENT. I'm only going to concentrate on ENT because there are many, right? So the most important and the most commonly used, which is currently available in market, is omalizumab. Omalizumab is an antibody to IgE, which is responsible for allergy. It is administered subcutaneously. Indication is nasal polyps and asthma. So nasal polyp and asthma. These are the indications for omalizumab. Another drug that is available in the market is mepolizumab and reslizumab. These are antibody to interleukin 5, and benralizumab, which is antibody to interleukin 5RA. So these are used for Chuksta syndrome, which is eosinophilic granulomatosis with polyangiitis. These patients will also have polyp. So they also have chronic rhinosinusitis with nasal polyp. So mepolizumab is used in nasal polyps. So this is again used in nasal polyp. Omalizumab, mepolizumab. There is one more drug which is dipulimab, which is anti-interleukin 4RA. It is used again in nasal polyps with children more than 18 years of age, and it is also used in moderate to severe asthma. So if biologics is asked, you have to write about omalizumab, you have to write about mepolizumab, which is anti-interleukin 5, and you have to write about dipulimab, which is anti-interleukin 4RA. So these three molecules you have to mention, and you have to mention that this is basically used for asthma, but they can be used for allergic rhinitis, they can be used for nasal polyps. And one more biologic therapy that is being used, that is being experimented, is tympanic membrane regeneration using heparin binding epidermal growth factor like growth factor. So this is known to produce regeneration of the tympanic membrane. Biologics for head and neck squamous cell carcinoma. So here there are two. One is your cetuximab, second is your trastuzumab. Cetuximab is your monoclonal antibody targeting epidermal growth factor receptor, and trastuzumab is your epidermal growth factor antagonist. receptor antagonist. That is your trastuzumab. So cetuximab, monoclonal antibody, epidermal growth factor receptor. I can't help it. You have to rattai marna padega because much of it is just the names. So I suggest you take it down and you ratta maro. Cetuximab and trastuzumab. These are the two biologics chemotherapy for head and neck cancers. So the response is usually correlated with an acneiform rash. It's an anti-tumor antibody for squamous cell carcinoma of the head and neck. Trastuzumab is for salivary duct carcinoma. Trastuzumab can also be used for head and neck squamous cell carcinoma. So cetuximab and trastuzumab. Here I wanted to add sublingual immunotherapy, which is new modality of immunotherapy, where the antigen preparation is delivered under the tongue, so in the sublingual fashion, which is safe and effective in the long run rather than injectable immunotherapy. So allergic specific immunotherapy, recent advance is your sublingual immunotherapy. Slit, what is called SLIT or sublingual immunotherapy. Another new advance in cochlear implant surgery. Cochlear implant has itself become old. What is called hybrid cochlear implant. What is hybrid cochlear implant? A hybrid cochlear implant is one which does not damage the normal hearing of the patient or minimally damages the normal hearing of the patient. So the patient can or the child can hear with the cochlear implant and also normal hearing. This is called atraumatic to the inner ear structures, and this is possible through slim modular cochlear implant. This is called slim modular cochlear implant or modular hugging cochlear implant. So this modular hugging cochlear implant does not disturb the inner ear. So patient has some residual hearing. So patient can use both the residual hearing and the cochlear implant for hearing. Such a cochlear implant is called a hybrid cochlear implant. So basically it does by using a shorter electrode and also an electrode that goes hugging the modulus. That is why it is called slim modular cochlear implant. Another concept in otology is teleotoscopy or remote otoscopy. Remote otoscopy is where the ENT surgeon sits in a very far place and the physician or the patient himself does the otoscopy and the diagnosis is done. So it is able to, it's a form of telemedicine where specialist care, otology care is able to given to distant population. There are two types of teleotoscopy. One is your guardian operated, second is your healthcare provider operated. Guardian operator is where the patient himself does the otoscopy. Second, healthcare provider operator is where the primary health center doctor or the staff nurse does the otoscopy. Again, artificial intelligence can be used for augmenting this teleotoscopy. So teleotoscopy, just an introduction. Another new concept in advancement in ENT is 3D printing. 3D printing is printing just like printing on a paper, but rather a three-dimensional scaffold or three-dimensional printout is taken out. So 3D printing, it can be used for generating temporal bone models, skull models, and it can also be used for printing body parts like your arms and ears, pinna, hearing aid molds. It can be used for printing larynx for learning, medialization laryngoplasty. So these are some of the applications of 3D printing in ENT. Basically what it does is use the CT data for generating a 3D model, and then this can be used. This can be used for learning surgery. It can also be used for printing missing body parts, like for example your pinna, your tip of the nose, or your ears, or hearing aid molds. Surgical aspect, you can learn surgery on 3D printed models, like for example 3D printed temporal bone and 3D printed skull, where you can learn facial-maxillary surgery. And in 3D printed larynx, you can learn about the laryngoplasties. Another new advancement in ENT is endoscopic thermography. It is the heat emission by the tissue. So basically it creates a thermal map of the vocal cords. So endoscopic laryngeal thermography is used for detection of inflammatory process of the vocal cords and mechanical strains and before and after surgery. So basically used for delineating mechanical strains before and after surgery. It is used for early detection of inflammatory process of the vocal cords. Basically it detects the heat given off by the vocal cords. So it can be used for cancer detection, where it is particularly used in breast. It can be used for fever detection, like for example in COVID. It can be used for vascular problems, and it can be used in inflammation. So in inflammation is of important role, endoscopic thermography of the larynx. Another advancement is your arthroscopy of the temporomandibular joint for treatment of temporomandibular joint conditions. This is used for treating joint conditions which are not responding to medical therapy. Arthroscopy is of two types, primary arthroscopy and arthroscopic discopexy, arthroscopic joint debridement, lysis and lavage, synovectomy, installation of steroids, suture discopexy. The main problem of arthroscopy of temporomandibular joint is injury to the temporofrontal branch of the seventh nerve. This is what happens if you injure the temporofrontal branch of the seventh nerve. So the patient can no longer raise the eyebrow, the upper part of the face, especially the forehead, becomes paralyzed. So arthroscopy of the temporomandibular joint for TMJ syndrome. So you can do variety of procedures via arthroscopy. Another new concept in ENT is active middle ear implants. There are three types of active middle ear implants: vibrant sound bridge, Carina, and NY Medical. There are three types of active middle ear implants. So these are basically replacement of hearing aid. These are implantable hearing aids, and the main prerequisite for active middle ear implant is that the middle ear should be disease free. Only then the active middle ear implant will work. It is not for use in CSOM or ASOM or some form of ear infection. The middle ear should be completely disease free. It acts as a replacement for hearing aid basically. So there are two types of active middle ear implants because it can come as a question: totally implantable middle ear implants and partially implantable middle ear implants. Totally implantable, पूरी तरह body में fit हो जाएगा, completely inside the body, nothing is there outside. Partially implantable, there will be a speech processor outside the ear, just like your cochlear implant. There will be a speech processor. So one of the implant which is most commonly used is vibrant sound bridge. It is the most commonly used middle ear implant worldwide. It is partially implantable. There is a speech processor outside the ear like a hearing aid, and then there is a floating mass transducer FMT which is attached to the long process of the incus. Indication I told you, middle ear and middle ear should be completely disease free, and the patient may have moderate to severe sensorineural hearing loss of more at the higher frequencies. Second, totally implantable middle ear implant, which is called Carina, which is produced by Cochlear Corporation, the same company that produces the cochlear implant. It is placed beneath the skin. It's totally implantable, but they say the battery life is only 10 years. Uske baad you have to do resurgery and put the new implant. Okay, indications are sensorineural hearing loss with no disease in the middle ear, with a hearing threshold between 35 to 85 dB, and hearing loss of higher frequencies. Then there comes the semi-implantable Codax hearing aid. So this is again used for, this is a very unusual indication. It is used for mixed hearing loss due to autosclerosis. So Codax is the third type of active middle ear implant. It is used for profound mixed hearing loss due to autosclerosis. So it can be used after a failed stapedectomy, okay, and it is inserted via a stapedial prosthesis. So Codax, Carina, and vibrant sound bridge. These are the three types of active middle ear implants. Next, regarding cancer therapy, one of the important new investigation that is being used nowadays is your positron emission tomography. This uses 18-fluorodeoxyglucose, D-glucose, and there is higher glucose metabolism of the cancer cells. So this dye is taken preferentially up by the cancer cells and this appears bright, just like you can see in this picture. One problem of PET is that Warthin's tumor and inflammation will also appear bright because they will also take up the glucose. Important indication for diagnosis for doing a PET is the detection of systemic metastasis and also recurrence following radiation, chemotherapy or surgery. So recurrence के लिए भी है और primary detection के लिए भी है. If somebody is saying, how do you detect systemic metastasis? How do you detect liver metastasis? How do you detect mediastinal metastasis? you do a positron emission tomography or CT-PET, and you can detect the systemic metastasis. How do you detect recurrence after radiation chemotherapy? Patient is asking you, you do a PET scan. Another new concept in head and neck cancer is your sentinel node biopsy. A sentinel node is the first draining echelon node of a tumor of a specific site. For example, tonsillar tumor, you all know the first node will be the jugulodigastric node. So first draining echelon node, you do the biopsy and you look for tumor. If you find it is positive, you do further, you choose. So you go on, choose the nodes by doing selectively choose the nodes and do the dissection. This is called sentinel node biopsy. Locate the sentinel node and selectively remove it. How do you locate the node? Using lymph scintigraphy, using handheld gamma probe, or you can use a PET CT scan, right? You can use the PET scan to detect, or you can use a handheld gamma probe, or you can use a lymph scintigraphy. These are the three ways of locating the lymph node. Here you can see the lymph node as a black signal. So this is called sentinel node biopsy. So removal of the draining or first echelon or sentinel nodes of a tumor. Next investigation, recent investigation, is your contact endoscopy. Contact endoscopy is used to evaluate the vocal cord lesions, especially used in vocal cord lesions, where in contact endoscope, this endoscope touches the mucosa, and then you are able to see the microscopic patterns via the special endoscope. So basically microscope और endoscope का combination है contact endoscope. Okay, so microscope की जैसे you are placing it on the tissue, फिर वो उसमें तुम्हारा टिश्यू का माइक्रोस्कोपिक एनाटॉमी दिखेगा, उसको हम लोग बोलते हैं कॉन्टैक्ट एंडोस्कोपी. Contact endoscopy with fluorescence study is called compact endoscopy. Basically what you see is, you see the abnormal vascular patterns. Like in this picture, you are seeing abnormal vascular loops. So you see abnormal vascular patterns, and these patterns are characteristic of malignancy. So you see for abnormal vascular patterns and make a diagnosis of early malignancy, and that investigation is called contact endoscopy. Contact endoscopy and compact endoscopy are used in supraglottic and laryngeal lesions. They are used in supraglottis and larynx basically. Another new investigation that can be used is narrow band imaging. So narrow band imaging, again like contact endoscopy, here you can see it will show you abnormal vascular pattern and helps you make a give you a idea where is the tumor and where to take the biopsy. That is the role of narrow band imaging. Helps you clue for where you take the biopsy and whether the growth is there, where is the growth, where is the extent of the growth. So it helps you in staging and helps you in taking the biopsy. Basically shows you an abnormal vascular pattern, and the light used is a special light which is called a narrow band imaging. Narrow band light is used. And another new concept in radiation therapy is called intensity modulated radiation therapy. One of the biggest problems of radiation therapy is your xerostomia. Patients cannot tolerate xerostomia, and the way to prevent xerostomia after post-operative radiation therapy is by your intensity modulated radiation therapy. Here the intensity is modulated using multi-leaf collimators, okay, and the beam is thrown around in such a way that the surrounding tissue is not damaged and the tumor is selectively targeted. So this is the new investigation in new modality in radiation therapy, which is called intensity modulated radiation therapy. पिछले जमाने के machines, they used to use cobalt 60, and that cobalt 60 will remove and all the radiation will just bombard the tissue, right? This modality is no longer good because it simply burns through the tissue, right? Here you use multi-leaf collimators to specifically target the tissue while sparing the normal tissue. This is called intensity modulated radiation therapy. This is the last slide. Again, this is itself a very big topic. Newer audiological tools, I'm just mentioning for completion's sake. One of the important new audiological tool is autoreflectance audiometry. Basically uses, instead of measuring the impedance, it measures the reflectance of the tympanic membrane to detect the condition of the middle and the inner ear. Multi-frequency tympanometry. Here other frequencies, many other higher frequencies are used for recording the impedance audiogram. Stacked ABR, this is used for detecting. This is the special technique called stacking. First Bera is done, and then you have the stacked Bera. This stacked Bera is used for detecting, is more sensitive for detecting vestibular schwannoma. And then there is CHAMP. This CHAMP, cochlear hydrops analysis masking procedure. This is used for detecting This is used for is a new investigation for detecting your Meniere's disease. This is the modulation of the basilar membrane, modulation of the properties of the basilar membrane because of endolymphatic hydrops. And this modulation, this change in the properties of the basilar membrane are detected by a special masking technique. And this procedure is called CHAMP, which is called cochlear hydrops analysis by masking procedure. And finally, a new investigation which has come up, which is called vestibular evoked myogenic potential. So this basically tests the integrity of the saccule. So basically tests the integrity of the saccule. The saccule is the one that produces this vestibular evoked myogenic potential. So if this wave is elicited, that means saccular integrity is good. Thank you. This is the part where I yeah, this is the part where I take questions. Are there any questions? Is there any part that you feel has? Yeah, are there any questions? Yeah, I have some questions here. Can you hear me?
Yes, sir, you are audible clearly.
Yeah. So there are some questions here. I'm not. Sir, does energy equip? Open it. Sir, does energy equipped? Energy equipped? Yes, yes. So Monica here asking me whether the energy equipped microdebrider is different from normal microdebrider. Yeah, it is a recent advance in microdebrider where you are able to do monopolar or bipolar cautery through the microdebrider itself. So energy equipped microdebrider is different. Cobblator, sir, powered instrument cobblator. Yes, cobblator is also a type of powered instrument. Okay. Third question is sentinel node biopsy is not clear. Can you please explain it again? So basically, see, you have a tumor and you have the lymph nodes that drain those tumors, right? For example, you have the tonsil, and a tumor of the tonsil will first drain into the jugulodigastric node. So you go and selectively target that jugulodigastric node when you have a tumor of the tonsil. So if you have tumor of the tongue, tip of the tongue, you selectively target the submental node, right? So you selectively targeting that lymph node and searching for metastasis in that lymph node by excising that lymph node is called sentinel lymph node biopsy. Very simple concept. जहां पे tumor होगा वहीं ढूंढना, rather than going and searching for it through the whole world, searching for the metastasis in the sentinel or first echelon lymph node. But the problem with most this sentinel lymph node biopsy is that many of these oral cavities especially have draining into the retropharyngeal and the parapharyngeal nodes. So they will also be involved. They cannot be targeted directly, right? So that is actually a problem with sentinel lymph node biopsy. So I hope I have clarified myself. This is called sentinel lymph node biopsy. And how do you target the lymph node? By using some modality like your PET scan or your lymph scintigraphy or handheld gamma probe. So use that and you inject special dye and you locate that particular tumor and you locate the particular lymph node, you take a biopsy and you see if there is metastasis. If the metastasis is there, then you repeat the process. You go on search for lymph nodes. So this is called sentinel lymph node biopsy. I hope I am clear now. Sure, sure. She's asking me to share the PowerPoint. I'm sure I'm more than happy to share the PowerPoint with you guys. Where to someone Aishwarya is asking me where to read the recent advanced topics mentioned in the last PG of your preparation. Aishwarya, I should say that I have consulted the papers. This whole preparation of this whole thing is my lecture is prepared from papers. It's not prepared from the book. I did consult StatLoff, which has got many recent advances. I also consulted symptom-oriented otolaryngology. I also consulted Scott and Brown, but majority of my content is from recent advances is from papers, OCNA, Otolaryngology Clinics of North America. You can see the pictures also I have reproduced from Otolaryngology Clinics of North America. The problem with recent advances is that it's just very vast. Even now it is not complete. There are sure 10 topics that I have missed. So I just went through the papers and thought ye important hai, this student should know. So I selected those topics and presented. For recent advances, you better read the journals, latest journals. That's the best way of knowing about recent advances. Because किसी भी book में सारे recent advances नहीं मिलेंगे. Take sir. Thank you for the sir out of tips for supra sir volumetric modulated arc therapy. How it is different from intensity modulated. One student has asked me what is volumetric modulated arc therapy, how it is different from intensity modulated arc therapy. I tell you this, what all these technologies are patented, right? So one machine will have, it's just like your ventilator, right? They have different protocols, and each protocol is patented. So one cannot copy the other. Basically do the same thing actually. So volumetric modulated arc therapy is just like your intensity modulated arc therapy. It's just another technology where the arc of or a arc like beam of radiation is produced, and that arcs intersect in the tissue, and then you have the place where the intersection of the arcs, that is where the maximum radiation is delivered. So it is another new technology. There are many new protocols. All of these are patented, and each machine has its own protocol for delivering it. So volumetric modulated arc therapy, what is called arc therapy, arc radiation therapy, is where the radiation beam is in form of an arc, and places where the arcs intersect, that is where the maximum radiation is delivered. So this is another protocol. I told you, just like your ventilator. It's another protocol, and another machine does that, and that machine is a proprietary machine. So they buy the machine and give the radiation therapy. All are essentially same. The main advantage is that the collateral tissue damage is minimum, even with arc, even with intensity modulated, and the incidence of xerostomia is much less. The arc therapy is considered to be even more recent than intensity modulated. They say that tissue damage is the least in this, and the time duration for radiation therapy is reduced to very less in arc therapy compared to intensity modulated radiation therapy. The time duration is much less. These are the advantages of arc therapy. Stem cells. I already told you about stem cells. The stem cells, the role of stem cells is in ENT is for regeneration of the tympanic membrane, for regeneration of the outer hair cells, for vocal cord regeneration. These are the three places where stem cell therapy is coming up in ENT: for regeneration of the tympanic membrane, for regeneration of the outer hair cells, and for vocal cord regeneration. So these are the three places. Please remember, stem cells are coming up. So somebody has asked me about cochlear endoscope. Cochlear endoscope, that's where you basically use a small endoscope to visualize the inner ear, right? Okay, so I'm not very clear on it, but the thing is that you basically use a very small endoscope to visualize the inner ear. That is your cochlear endoscope. I don't think anybody will be asking about it because there's no practical indication still now. Okay, some of the I only chosen ones that are actually now. If you look at vocal cord regeneration, it is a concept. Now cochlear endoscope, it does not come up into a clinical practice much. It's still an experimental modality. Supravital staining is another thing that is used in combination with contact endoscopy, where a special stain is applied, and that stain specifically stains the cancerous tissue, while does not stain the normal tissue. So that is what your supravital staining is. So supravital staining is specially used in combination with contact endoscopy and your narrowband imaging. So I think that's about it. Are there any more questions you can ask me right now? I'll try to answer the best. And if there are no other questions, he's asking about Dawn's test. I wanted to talk a little bit more about that, but I was hard pressed for time. The Dawn's test, again, the Dawn's test is nothing but is a way of detecting vestibular schwannoma by using a stacking of your basically there is arrangement of the cochlear nerve has got the various fibers, and each fiber has got a particular linkage to a particular place, which is called tonotopic arrangement of the cochlear nerve. So basically use that information through the BERA. You basically do a BERA, then you obtain the tonotopic information or the place wise information. कौन सा fiber कहाँ पे जुड़ रहा है, ये information can be obtained by stacking the BERA. What is called a procedure called computer will do that. It's called stacking of the BERA. With that, they say that the ability to detect the your vestibular schwannoma is much more better than your direct BERA. BERA से भी ज़्यादा sensitive हो जाता है because you are combining information from different frequencies. You are comparing information about different frequencies. See, for example, अगर vestibular schwannoma 2000 के hertz को ही affect कर रहा है, so that alone will get affected, and you are able to make pinpoint that definitely vestibular schwannoma is there because 2000 hertz is not being conducted. So that frequency specific information is obtained by stacking the BERA, and this test is called Don's test. Again, there are many things. Somebody is asking me about CUSA. I don't know what that is. So thank you very much. If there are any more questions, if there are no more questions.